Hello, everybody. I'm here today with Dr. Philip Cooper, and it's a pleasure to have you.
Thank you for inviting me, Becky.
You are very welcome. Now, you're going to be leaving the palliative care department. So can you tell me what your role was at the Straight Richmond, or still is, really?
Well, for the last 13 years, I've been providing palliative care in this southwest corner of Cape Breton, everywhere from Lordways to Arishat to Pottletech to West Bay Road and up to Juddick on the number 19 and Port Hawkesbury. So it's a big patch that we cover. When I first started coming here in 2011, I came every 3 weeks, but quickly the program developed to the point where it was clear we needed to do more than just once every 3 weeks, and for most of the last at least 10 years it's been every week, and it's a busy day that I spend here every Wednesday, like today when we're here, seeing folks mostly at home, but we start our day with the palliative care team at the Straight Richmond Hospital and see people who are either in hospital or who are well enough to come to see us in the palliative care family room there for visits. So we begin our day in the Straight, but most of my work is out in the community, not in the hospital.
Right, so a lot has changed over the years. Yeah, so, you know, obviously your program is very successful, and I know that so many people really appreciate what you do and are very grateful for what you do, you know, myself being one of them. But, you know, is it something that you think will continue?
Well, I certainly hope so, because there's an increasing need for palliative care services, not only here, but everywhere in our world. But palliative care is a young specialty. It only really began, I have realized as I've done my research over the years, it was beginning when I was beginning my medical studies back in the 1960s. So palliative care is a young specialty. I often reflect that prior to the middle of the 20th century, all medical care was palliative because we didn't have treatments for most of the things that ailed humanity, and so people were looked after as people rather than as we came to do with the modern medical model of care, treating diseases and forgetting the person. And palliative care, I believe, puts that all back together again. We don't focus on the disease, we look at the whole person and their family, because that's where people need help.
Absolutely.
So palliative care is a relatively young specialty. It's traced back to Dame Cicely Saunders, Dr. Cicely Saunders, who became Dame Cicely, who opened St. Christopher's Hospice in London in the late 1960s. I visited there as a student, little realizing how important the work that she was pioneering there would be in the course of my later career. And from St. Christopher's in London, the palliative care philosophy spread around the world, coming to Canada in the late 70s to the Royal Victoria Hospital in Montreal, where Dr. Balfour Mount, who's still alive and still leads the program there, started the first palliative care unit in a hospital and started, in fact, he coined the term palliative care in Montreal, and from there palliative care spread all around North America. You may not know, but the word palliative care relates to a pallium. We talk about a pallium as being what a pope wears. It's like a cloak. It's a supporting comfort cloak is what a pallium is, and that's what Balfour Mount in the Royal Victoria Hospital tried to provide after studying with Dame Cicely in London. And that's what we try to provide here now.
But you do.
Well, I hope we do.
You absolutely do.
I hope we do, yeah.
I mean, you know, there have been so many people that have been touched by your program, you know, and how many people it's helped. And I mean, I'm not just the patient, the families of those patients. You know, it must feel great to know that you've had that positive impact. It
does, and I'm very grateful for that positive feedback. the thing that I have learned over the course of my career, and I've actually been a physician 50 years this year. It's
Wow.
50 years since I graduated, and most of my life I was a surgeon. Actually, Balfour Mount was also a surgeon before he became a palliative care physician, so there's an honorable tradition of surgeons going into palliative care. And I treated diseases. I really wasn't terribly interested in the person. And even when I started doing more work in the field of oncology and cancer work, we're treating the cancer, we're not treating the person. And it took me a long time to figure out that it's actually the person that we should be treating. And so we in palliative care, at least I hope we do, focus on the person as much as the patient. And that's something which is a relatively recent development, even in the last 13 years since I've been doing palliative care.
Well, now, as you move on to the next chapter, what are you going to be doing next?
Well, I thought I was here for keeps. I've been living in Antigonish very happily for nearly 30 years now, and I'm very settled in the community and love coming here every week to Cape Breton. I thought that was it for us in terms of moving and retiring. But I was approached again by friends and colleagues in the other end of the province and asked to come and help sort out the palliative care needs of the Tri-County Southwest Nova region, where there are 3 counties, Yarmouth, Digby and Shelburne, that uniquely in this province have no palliative care physician. There is no palliative care physician in those 3 counties. And so the opportunity of doing palliative care full-time, which is what I have come to love, was very appealing, even if it meant uprooting and moving home. It didn't do any harm to the discussion that my wife happens to be from that part of the province. She's Acadian from Clare, and so we have family and connections down there, and so that'll make the move easier for sure.
I'm sure that having you there is going to bring even more comfort. Well, they're going to bring comfort to that area. You know, if they're underserved. So, you know, that leads me to my next question. You know, the healthcare system now is, you know, it needs improvement. Like, I mean, I think that the doctors are overworked, the medical facilities are overrun. You know, do you have hope that will improve over the next few years, or?
I have hope. I never give up hope.
Well,
Being
no.
a palliative care
Of course
physician,
not.
we never give up
No.
hope, but it is certainly challenging. I can look back on 50 years in medicine, 40 of them here in Canada, and I have to say that the situation in the healthcare system at large is as dire as I have ever known it. It's not physicians alone, it's
No.
nurses, it's
Yes.
healthcare workers, of laboratory technicians, it's ambulance crews, it's hospital beds, it's nursing home beds. The whole system is stressed beyond belief at the moment, and it's a very difficult system to work in and a very difficult system for patients to be cared for in as well. It's a real challenge.
Oh yes, absolutely. So now, what do you see happening with the palliative care at the Strait Richmond?
Well, there will be another physician taking over my role, that's for sure, and I'm one part of a team. Palliative care is a team sport.
Right.
So the 3 key specialties that Dame Cicely saw as being the core of the palliative care team from the very beginning were social work, nursing, and medicine. She was all 3. She began life as a social worker, she became a nurse, and then eventually became a physician as well. So she was the first single-person palliative care team. And we work in this region as a palliative care team. I work with the nurses based at the Strait Richmond Hospital. We work with the continuing care nurses who provide the day-to-day hands-on care in the community, but we also work with physiotherapy, occupational therapy, pharmacy, pastoral care, all part of the palliative care team. So there'll be someone coming after me who will continue the work and I hope continue to grow the program. The demographics are such now that our baby boom generation is at the peak of its age and peak of cancer incidence as well. And as everyone watching this will know, the incidence of cancer in Cape Breton is amongst the highest in Canada. And so there's a huge problem with looking after cancer, although one of the things that has changed in the last 12 years that I've been doing palliative care is that although at the beginning of that time, most of the people we looked after would have been patients with cancer who were close to the end of their lives, now we look after a large number of people with chronic diseases, heart failure, lung failure, kidney failure, brain failure, a lot of chronic diseases. So we follow folks sometimes for years. It's not just end-of-life care. And those are people who very often cannot get to see family docs. They can't get to a hospital unless they go by ambulance, calling 911. People who are stuck at home, sometimes in very remote locations, with perhaps limited family supports. So we have to try to provide all the things that those folks need in order to be able to carry on living. And the focus of palliative care, which I think most people don't really understand. Most people, when they're introduced to us as the palliative care team, the eyebrows go up and they think, oh my God, I'm going to die. This is the end. They're going to hold my hand while I die. I explain to people, because most people think that, that's the prejudice most people have, and that's the way palliative care still is in many places, unfortunately. But I explain that what we're actually focusing on is helping people with quality of life and treating symptoms and helping them to live as good a life as they can until they die. So I say, it might interest you to know, we spend 95% of our time helping people to live, and perhaps 5% of our time helping people to die. Oh, well, that sounds good. Bring it on, right? And so that's what we try to achieve, to help people's quality of life be as good as it possibly can be.
And that's very important. That's so important. That you're right. People do believe that when you hear palliative care, that's what you're. But I think that the whole idea that you're talking about, the team that you're involved with, I mean, what a great resource and what a great privilege to have people that care enough to do that. Because people don't just say, oh, well, I'm going to do this. You know, you have to actually, you have to feel that, right? You can't just make it up. So I'm just delighted that it's going to continue. You know, I mean, I have many friends, and we all do. We all have many family members and friends who, right now, are going through different diseases. You know, cancer, you know, different respiratory illnesses, mental illness. So, what a wonderful gift palliative care actually is. So, thank you very much for being a part of that team. And I'm sure that when you go to your next team, you're going to be just as important and just as engaged. So,
well, Becky, you say thank you, but I don't feel I need thanks because I love what I do. And most people in palliative care do love what they do, which is why they're doing it. Yeah. But it does mean that you have to give of yourself as well as, it's not just a question of getting the right drugs. Right. And I sometimes say, with tongue in cheek, it's more about the hugs than the drugs. The drugs are the easy part. It's more than just pain and symptom control. It's about the bigger picture, about the things that are really important to people in their lives, and particularly as their lives draw to a close. It's helping people navigate these challenges and helping their families to help them navigate them as well.
And showing the patients so much respect is what I've noticed about a lot of palliative care people and nurses, doctors that I've come into contact with. I think it's a respect thing. You know, I know that I respect people who come to me when they're sick and say, you know, I need to talk about this. Well, I respect that, and I'm going to listen to you. And I know that the team does a lot of listening as well, and a lot of those hugs you're speaking of. So, what can the general public do to ease things up on the healthcare system?
I have tried over the last 13 years to impress on people here in Richmond County in particular that what we have here is special. We are actually blessed by a palliative care system which works in a way that people elsewhere in this province are not blessed. We are able to offer coverage and care that is not offered in the city of Halifax, for example. There are counties such as the 3 counties that I'm about to move to that have no palliative care physician. So what we have here is remarkable, but it is a team effort to provide that care. So I think it will continue to grow. I think we've almost been victims of our own success because we're asked to look after folks who may not be appropriate for the palliative care program. And sometimes we'll see folks and make some suggestions and then pull back and not follow them in the longer term. We follow in our program on an average around 50 people at any one time. And our team meets every week online on a Tuesday to discuss all the people that we're following in the program. So that's including the various members of the palliative care team, including the continuing care nurses who provide the day-to-day care. We meet and discuss all 50 odd of the people we're following, and then the following day, like today on a Wednesday, the nurses will decide which 10 or so we need to be seeing, mostly at home and following, but there are calls 7 days a week. People don't just get sick on Wednesday. So there are lots of needs which happen throughout the week and also at the weekend. I've noticed that people in Richmond County often choose to die on a weekend when there are limited resources around in the community, and so I get a lot of calls at the weekend from families, nurses, pharmacies, funeral homes, trying to help people stay at home to die on a weekend. And most people would prefer to die at home.
Yes, I know
Most
that.
people would prefer to die at home if you ask them. But then you say, when it gets closer perhaps, most people will also say, well, of course I'll go into hospital for my end-of-life care. And I'll say, why? And they say, well, I wouldn't want to be a burden on my family. And I say, well, did you ask your family about that? And the family will nearly always say, particularly here in Richmond County, well, that's actually part of our job. We want you to stay at home. And we managed to achieve a home death rate here, which is more than double the provincial average. Wow. And of that, I am proud.
Wow.
The majority of people, more than half of people here, manage to die at home. Wow. But that requires a lot of commitment and support from family, friends, community, and the palliative care team for that to happen. But and I say, you shouldn't be thanking me. I feel privileged to be able to be part of this very intense period in people's lives as individuals and as families, and to be close to folks, forming quite deep relationships quite often that may not be very long, but they're deep, and sharing with them this difficult time in their lives and suffering. And we're all, I don't know whether everyone watching this realizes this, but we actually are all going to die. And although I've had Catholic priests tell me that this isn't the case, we are probably going to suffer, even in this modern age with modern healthcare. Most of us will suffer before we die, to some extent. And a lot of that suffering, we hope, can be relieved. But life is about suffering, and eventually we die, and dying is a normal part of life. Most people deny that. Most people don't want to think about that, but that's the reality. And so the challenge for us in palliative care is to help people to come to terms with that, be aware of their own mortality. I'm an Anglican priest. You may not know that, but it was palliative care that I blame for leading me to discernment, which led to my becoming an ordained Anglican priest. And yet I often refer to words of wisdom from the Buddhist tradition. The Four Noble Truths of Buddhism say, to paraphrase, life sucks, here's why, you can change it, here's how. I'm going to say that again because I think it's important. Life sucks, we're all going to suffer, here's why we suffer, you can change it, and here's how. So that has an impact on the way I approach palliative care, And I help, hopefully, people to come to terms with the inevitable suffering in their lives and their deaths. And to make meaning out of that suffering is our challenge. And at the end of all that, hopefully, people can say, yes, that was a good death. There is such a thing as a good death. And a lot of it is about the way families respond to the death of an individual. People think, it's my life, it's my death. And I say, no, it's not. People, others share your life. They share your death. They suffer with you, and they want to be part of that process. And you're not suffering alone. You're sharing that with your family, with your friends, with your community. And we're part of that as well. And we want to make this as meaningful, if not necessarily pleasant, an experience as possible, so that people can look back and remember the good things that happened when they were in the process of dying. The family can look back and say, this was a good thing. There's a lot of reconciliation happens around a death, around a deathbed. I remember a couple of years ago, there are lots of stories in palliative care. Stories come out of palliative care, and there's a lot of storytelling in palliative care. I love stories. Some people even call it narrative medicine. But I remember several years ago, I looked after a man who'd had a rough, tough life. He was basically alcoholic. He was estranged from his family. He'd been through 3 marriages, had multiple adult children from whom he was estranged, grandchildren he'd never met, and he knew he was dying. And he said, I'm dying, that's it, no big deal, nobody cares about me. He lived like a hermit. And I said to him, why don't you, before you die, contact one of your family with whom you have some contact and tell them, just so you know, I'm dying. I'm only going to be here for another month or 2 at most. And if you want to come and see me, then you need to do it now. So I said, he said, I'm not going to do that. I said, go on, indulge me, just for me, do that one thing. Call your one relative who you have some contact with. So he did. And I heard a couple of weeks later that he'd called this one relative who had a friend who ran a campground. And the friend said, well, we'll close the campground for the weekend and you have a family gathering before your father dies. Wow. And I think 50 or 60 members of this extended family gathered in this campground, and he was the center of attention. And he met grandchildren he'd never met before, and he made his peace with family to a certain extent, but at least he gave his surviving family the opportunity to say, well, yes, we met him, we saw him, we told him we loved him, in spite of all the things that had gone on in our shared history. But as a result, they could carry on with their lives, rather than saying, well, he died, he didn't want to see us, he rejected us, even as he was dying, he didn't want to see us. So there was a wonderful moment of reconciliation for that whole family. And halfway through the weekend, he got much sicker, came into hospital, died within a couple of hours. But for that family, looking back on that 48 hours that they had together with him, it was a wonderful experience. An experience of growth, an experience of grace, an experience of family love, in spite of his very, very difficult history and very difficult personality. So it was great to have been able to kind of be a catalyst for that moment, that family reconciliation.
Yeah, also brought quite a bit of closure to that family, I'm sure.
I would hope.
Oh, I would think so. So what do you do to de-stress?
My wife and I walk our dog. We read a lot together. She sews or knits or quilts, and I read to her while she sews or knits or quilts, so we read a lot of books together. I try to sleep. I find as I get older I sleep more, and I think that's good.
That is good.
But I have a lot of other things that I do in my life. I'm active in music and theater, and obviously I'm active in our church as well. So I have a lot of other things away from palliative care and away from medicine that give me fulfillment and give my life meaning as well.
Right.
And I think being around people who know that their life is coming to an end and appreciate the value of every day in a way that most people don't and just take for granted, it helps us as palliative care professionals realize that we need to enjoy and take advantage of every day as well, because none of us knows which day will be our last. So we need to make the best of today and not be obsessed with regrets for yesterday or fears for tomorrow. We need to be living in the moment and enjoying today, doing what we can to make today better for ourselves and for those around us.
Making the best of it.
Exactly, yeah.
Because I always say, you know, we only have one life.
Right.
Make the best of it.
Right.
And I think that a team like yours probably helps people make the best of it.
I hope so.
Quite a bit.
I pray that that will be the
Oh, I
case.
think you're correct. Thank you so much for coming.
You're welcome,
I wish
Becky.
you every success at the other end of the province.
At the other end.
And, you know, I'm sure you'll make new friends, you know, and help many more people for many more years. So whether you want me to say thank you or not, it's still within me to say thank you.
Well, I'll leave behind many friends here as well. I was actually talking to a lady who I've known, her and her family, for many years, looking after them in palliative care, and telling her that I was leaving. And she said, I want you to know that I never thought of you just as my doctor. I thought of you as my friend.
Yeah.
And I said, well, you couldn't pay me any better compliment than that.
That's correct. You take care of yourself.
Thank you, Becky.
Thank you.